Great. Well, hello, everyone. Happy Monday. My name is Josh Fox Fuller. If you can go ahead and hit the next slide for me, please. So welcome to the No Neuropsychology Didactic Series today. We're all pleased that you could join us for this 11th lecture in volume 3 of our 12-week No Neuropsychology series, which brings you lectures from different experts in the field covering a variety of topics each week. Next slide, please. The series was created by early career neuropsychologists and trainees to provide free, high-quality didactic opportunities. Next slide. We would like to thank our sponsors for continued financial support of the series. Next slide. And before we start, we have a couple of disclaimers for the series. So this training is not meant to replace formal education in neuropsychology, and the views of the speakers are entirely their own. Next slide, please. Questions, this slide, here we go. Questions during the panel today can be submitted via the question and answer box in the lower left of your screen, and a recording of today's lecture will be provided on our website later this week. Next slide. Now it's my pleasure to introduce to you all Dr. Tracy Vannerstal for today's lecture on COVID-19 and including the state of the literature and the current clinical implications. Dr. Vannerstal is a board-certified clinical neuropsychologist and an assistant professor within the Department of Psychiatry and Behavioral Sciences and the Department of Neurology at the Johns Hopkins University School of Medicine. She completed her doctoral degree in psychology at the University of Maryland, Baltimore County in 2006, following a one-year internship in clinical neuropsychology at the Ann Arbor VA Medical Center. She then completed a 3-year clinical and research fellowship at the Johns Hopkins University Department of Psychiatry and Behavioral Sciences, and then joined the faculty in 2009, where she's currently an assistant professor and director of clinical training in the Division of Medical Psychology. Her work with patients provides insight and motivation for research, which focuses on developing methods to improve cognitive functioning in those at risk for neuropsychological declines due to illness and medical treatments. She's a member of the Johns Hopkins Post-Acute COVID-19 team, which is one of the earliest dedicated multidisciplinary COVID-19 survivorship clinics in the nation. Through this clinic and other research collaborations, she's working to understand the neuropsychological sequelae, clinical course, and treatment needs associated with the COVID-19 infection. I'll go ahead and pass it now to Dr. Vannerstal. Thanks for joining us today.
Thank you all for having me. All right, so what I'm going to speak about today are really sort of setting the stage for what are our expectations for neuropsychological difficulties following COVID-19. I'm going to touch briefly on mechanisms that may contribute to neuropsychological dysfunction, and then spend most of our time talking about the data on neuropsychological outcomes in a number of vulnerable populations, as well as the population more generally. And then I'll walk you through our PACT clinic and our initial neuropsychological findings and talk about sort of where I think the field is going to be going. So just so that we can sort of start with a review of terms, the first thing we'll note is that there are multiple forms of coronaviruses, which we've all now been aware of for well over a year. The SARS coronavirus enters host cells via the ACE2 receptor. This is a bit different from other coronaviruses like MERS that enter the host cells in a different pathway. So of course, COVID-19 is the clinical syndrome associated with the SARS-CoV infection, right? And so the first place when we're starting to think about what kinds of neuropsychological difficulties our patients might experience, there are two sort of literatures to look at. One is what we have seen in prior coronaviruses, and the other relates to our critical illness literature. And so as the pandemic was rolling out in May of 2020, a group from the King's College and the Maudsley in London published a meta-analysis of pooled data from studies that looked at the incidence of psychiatric issues after the SARS and MERS outbreaks in early 2000 up until around 2012. And so there were 7 studies that they were able to look at. And what they found is that in patients who were acutely ill and hospitalized, there were high rates of confusion or delirium, mood lability, anxiety, insomnia, and reports of thinking difficulties. And then when they looked post-illness, there continued to be elevated rates of those same issues, including insomnia, irritability, memory, fatigue, cognitive difficulties. The point prevalence for anxiety and depressive disorders was about 15%, and it was twice that, 32% for PTSD. However, if you look here at the number of studies and sort of the sample sizes, you see that most of these studies weren't terribly focused on cognitive outcomes or using any objective cognitive tests. So it really is a fairly limited literature in which we can sort of pull any expectations. I think where we have a lot more insight is from the critical care literature. So as everyone is aware, COVID is resulting in increased spikes in the number of patients who are needing to be treated in the ICU. And many of these patients are experiencing acute respiratory distress syndrome, or ARDS, and require mechanical ventilation. And we know from the critical care literature that up to 80% of patients who survive acute respiratory failure and receiving mechanical ventilation in the ICU will have new or worsening mental health, physical, and cognitive difficulties that persist there beyond their discharge. And this is known collectively as the post-intensive care syndrome. And so there are lots of reasons to think that this syndrome will play out in our ICU COVID patients as well. These individuals will have the added issue of, we know from sort of the SARS epidemic that the constant media coverage emphasizing high rates of death, that there's stigma due to community or family members blaming survivors for the spread of the illness. There's fear of infecting loved ones, dealing with grief related to the loss of close family members and survivor's guilt. So all of this sort of adds an extra layer of stigma and fear that can contribute to mental health outcomes that's relatively specific to COVID compared to our general PICS population. And so what we know in terms of cognitive difficulties following illness is that, certainly delirium is not good for our cognition. And in patients who have critical illness, the majority in many cases will experience delirium. When you look at patients after their hospital discharge, this is a well-cited paper from the New England Journal from several years ago now, where they're testing patients with the R bands at 3 months and 12 months after hospital discharge. And what we see is that patients are scoring more than 2 standard deviations below expectation at both the 3 and 12-month time points at about a rate of 1 in 4. And this is occurring regardless of patient age. So we're seeing these cognitive deficits even in patients who are under 50 years of age. And we know that longer delirium is associated with worse cognition and executive functioning, but not necessarily the use of sedatives or analgesic medication. So delirium prevention is really important for maintaining cognitive health. Similarly, when we look at psychiatric symptoms following critical illness, we see high rates of persistent PTSD symptoms 12 months out. 30% of patients reporting elevated symptoms of depression following their ICU stay. And while both ICU and PTSD are common following critical illness, there is evidence to suggest that depression in and of itself is predictive of poor cognitive outcomes in these patients, whereas PTSD is not. So what can we extrapolate from the SARS and critical illness literature really suggests that COVID-19 patients might be at risk for poor neuropsychological outcomes? And the question then is really, is this due to the hospitalization seen in our more severe patients or experienced by our more severe patients? Or is there also something mechanistic with respect to the SARS-CoV-2 infection? We now know that the disturbance of cognition occurs predominantly without infection of the CNS neurons. And so while the virus can enter the brain, it seems to really predominantly infect the vascular and immune cells. And so in some individuals, this infection triggers a massive release of cytokines and chemokines, other inflammatory signals that lead to disruption and dysfunction of the blood-brain barrier. That then activates microglia and astrocytes that really further promotes neuroinflammation and neuronal cell death. Additionally, microvascular infarcts and hemorrhages, which are really part of that systemic coagulopathy and vasculopathy of COVID-19, also seem to be really critical in the development of encephalopathy and delirium and some of the other neurological manifestations of COVID-19. And so I'm just going to sort of touch on that mechanism here and leave it there because I really wanted this to be more of a practical talk in terms of neuropsychological outcomes. But we do need to appreciate that given the enormous global burden of COVID-19, even a small proportion of individuals having post-acute sequelae could really cause a significant public health burden and be a real issue from a more public health perspective. So these are data from yesterday. Our nation is up to nearly 33 million infections. And so cognitive and mental health outcomes are getting a lot of attention from the NIH and other funding institutions as an important area of study in these large numbers of people who have been affected by COVID. And so when we think about sort of the mental health outcomes, data from early in the pandemic really relied mostly on surveys and self-report measures and things that were feasible in the midst of a pandemic when people were locked down. And so they tended to focus on mental health challenges due to the pandemic and quarantining, rather than specifically looking at function in patients who had COVID. But now that we're sort of a year plus into the pandemic, we're starting to get good objective data. And I really want to start by highlighting what we know about special populations that are particularly important to us as neuropsychologists. And the first are patients with psychiatric illness, right? So this is a paper from Lancet Psychiatry published in November of last year, where they were asking a couple of questions. First, is a diagnosis of COVID relative to other health events associated with higher rates of subsequent psychiatric diagnoses? And are patients who have psychiatric conditions at higher risk of being diagnosed with COVID-19 than those who don't have a prior psychiatric diagnosis? And so to answer these questions, they looked at electronic health data from 69 million individuals, 62,000 of whom were diagnosed with COVID-19. And the primary outcome was the incidence of a first psychiatric diagnosis existing over a period from 14 days to 90 days after a diagnosis of COVID. And they were, of course, sort of matching for risk factors for COVID and severity of illness. And they were comparing rates of these outcomes to rates that are seen following 6 other health conditions. So these are things like the flu, other upper respiratory infections, fractures, etc. And what they found was that a diagnosis of COVID-19 was associated with more first diagnoses of psychiatric illness in that follow-up period compared to all the other 6 control events. And so we see most likely were anxiety disorders, followed by depression and dementia in those over age 65. And we see here along the top panel, we see COVID in sort of that orangey pink, and in the bottom, that is the flu. And so we see sort of elevated rates of psychiatric diagnosis for COVID relative to the flu. And then down here at the bottom, we're looking compared to other upper respiratory infections. Additionally, when you expand the outcome to any psychiatric diagnosis, including a relapse of psychiatric conditions that had been present, we're seeing, about an 18% estimated probability of having a diagnosis post-COVID. And this is seen even when limiting the sample to those individuals who did not require hospitalization. So it isn't simply that sort of PTSD, anxiety, depressive symptoms that we see in the ICU setting in that critical care literature. It really seems to expand to all levels of COVID infection. And then when you turn that question around and say, is having a previous or a prior psychiatric diagnosis, does it put you at increased risk for contracting COVID? The answer is certainly yes. So it really tells us that our patients with psychiatric conditions are vulnerable when it comes to the likelihood of contracting COVID. And now that we are in the setting of vaccinations, it really points to us needing to have a discussion with our patients about their willingness to be vaccinated and sort of helping to facilitate that discussion where appropriate so that we can help protect these vulnerable patients. Another group that we're always very concerned about, particularly in the context of COVID, is our patients with pre-existing dementia. And so these are data that came out earlier this year, a retrospective case control analysis looking at the electronic health records for 62 million adults, more than 1 million of whom had a dementia diagnosis. And they wanted to see whether after you control for other important differences between people who do and do not have dementia, their demographics, their comorbidities, whether or not they live in a nursing home or assisted living facility, are people with dementia more likely to get coronavirus? Are they more likely to be hospitalized when they get that virus? And are they more likely to die? And what they found is that patients with dementia have twice the risk of contracting COVID-19 compared to their peers. And the rates were the very highest for individuals with vascular dementia, followed by young onset and then the other dementias. And it may be the case that patients with dementia are more likely to contract coronavirus because their cognitive compromise really hinders their ability to consistently adhere to social distancing, mask wearing, hand washing, and things like that. Additionally, the fact that vascular dementia seems to be most at risk, those patients are most at risk, really suggests that that already compromised vascular system may be maybe playing a role in terms of their risk for contracting COVID. Additionally, they also examined how sex, age, and race affected COVID-19 risk among patients with dementia, again, after controlling for relevant risk factors. And what they found is that there were no differences based on sex or age, but that when we're looking specifically at Black versus Caucasian or white Americans, Blacks with dementia were more likely to be infected by COVID-19 than whites with dementia, even after controlling for all of the important risk factors. And that seemed to hold across dementia subtypes in both vascular and Alzheimer's types of dementia. Additionally, minority individuals were more likely to be hospitalized, both for their coronavirus and for their dementia, and when they happen to have both conditions. So there was just an increased rate of hospitalization for those individuals. However, the mortality rate was not significantly higher for minorities relative to white patients, which generally parallels the larger COVID literature that tells us that members of underrepresented racial and ethnic minority communities are more likely to contract coronavirus, but may have equivalent survival outcomes in these adjusted models. The question remains in terms of other outcomes beyond just survival, sort of neuropsychological and physical health outcomes, I think are important things that we'll be looking at in the future. And then obviously there are significant concerns about how our patients with other pre-existing neurological and cognitive disorders fare with coronavirus. And here the literature really is quite limited. I just wanted to sort of give a little sampling of what's out there because it's really still in the very early stages. But the data do suggest that there's preliminary data to think that COVID-19 might be able to trigger an exacerbation of MS. Additionally, patients with Parkinson's disease tend to fare more poorly when they contract coronavirus, particularly if they're older and if they're already experiencing a dementia related to their movement disorder. Contrary to sort of the initial concerns that individuals living with HIV may be at increased risk for poor outcome, some of the data actually suggests favorable outcomes for persons living with HIV, possibly due to a protective effect of antiretroviral therapies. And then patients with epilepsy, there's some indication they may be at heightened risk for contracting COVID, but they don't seem to fare any worse in terms of major outcomes than those who do not have epilepsy. So when we think about just cognitive outcomes more generally, I think it's really important to remember that we're really still in the early stages of exploring these issues. Our studies are limited to a handful that really vary with respect to patient characteristics. We're just starting to get large, well-controlled, multi-site clinical studies underway, but those are moving, those are starting to happen. But the existing studies really vary with respect to our patient characteristics. So sort of demographic characteristics, illness severity, whether patients needed to be hospitalized or not, when cognitive assessments or neuropsychological assessments were taking place relative to the time of infection, and what domains were being assessed. There's a lot of variability across all of those issues. And so we're sort of putting together a puzzle piece by piece, but we still don't have that big picture as of yet. And so, I wanted to keep this really practical. So while there are a number of really interesting topics I think we could cover, I wanted to narrow our discussion of cognitive outcomes just to those studies that document objective cognitive findings. So objective cognitive tests, not simply self-report. I wanted to look specifically at studies that moved beyond screeners, so not MoCA or the TICs or things like that, but really use some of our more traditional neuropsychological tools that we're likely to be using when we see patients. And while the case series that have been done have been really, really useful in terms of setting the stage and getting us to think about what we might expect in terms of COVID outcomes, I really wanted to focus on the literature where there are sufficient sample sizes that can give us some sense of the lay of the land and some stability to the data. And so with all of those sort of caveats in mind, that gets us down to 5 published studies. And so my goal is to sort of walk us through those and then tell you about some of our data, which is not yet out, and have a discussion about those. And so the first data came out of China. It was published in June of 2020. And it's really remarkable. I mean, that's very early on, obviously, and even more remarkable because they had matched controls, which is something that I haven't seen in any other studies. So it seems like they peaked in terms of their wave of cases, and as their case numbers diminished, the research was able to pick up a little bit. And so the data sort of moved from east to west across the globe in terms of the timing at which we're getting cognitive outcome data. And so these were 29 recovered patients who were tested 2 to 3 weeks after they were infected with COVID. They're fairly young, in their 30s, 40s, and 50s, up to 60. They're tested early on. And there was a fairly modest battery of 4 tests. So looking at sort of processing speed and executive functioning, attention, sort of brief auditory attention, working memory, and a continuous performance test. And what they found is that there were group differences or trends towards group differences that favored the healthy controls on some of the metrics for the CPT, the continuous performance test. Additionally, the CPT reaction times were positively correlated with CRP levels of inflammation, suggesting that that inflammatory response associated with the virus was likely contributing to cognitive difficulties. But patients did not report elevations on their GAD-7 or their PHQ-9. Their scores were generally like 4 on average, so even below the cutoff for mild symptoms. So those were really some of the very first sort of objective data that came out. This was followed by data from Spain, where they tested 35 previously cognitively, physically, and psychiatrically healthy individuals. So that sort of knocks down the age range again. We're here in the 20s, 30s, 40s, and 50-year-old folks. These patients were tested 10 to 35 days after they were discharged from a hospital. So they're quite young, they're tested really early, and the battery of tests are listed here in the table. And what we see is that there were fairly frequent impairments on tests of letter cued fluency, trails B, so sort of mental flexibility, working memory. We saw less frequent deficits on tests of processing speed, category cued verbal fluency, attention learning, and memory. Additionally, subjective cognitive complaints were associated with the severity of anxiety and mood disturbance, but not with objective cognitive test performance. And that really parallels a lot of what we see in neuropsychology, where our subjective ratings of cognitive challenges really tie more closely to these emotional and fatigue related issues, more so than objective outcomes. More recently here in the US, a group out of Weill Cornell presented data from a much more diverse sample. Here, patients were not excluded based on the presence of pre-existing cognitive or neuropsychiatric conditions. So the data here are sort of nice because they tell you this is what's likely to actually come through our clinics. They're not sort of tailored to tell us specifically about COVID, but really about what we're likely to see in the mix of etiologies that are going to be contributing to the patient presentations that we're faced with. And so 64% of their sample had pre-existing cardiovascular and metabolic issues. They were assessed a little over a month, almost 2 months after they were admitted to an inpatient, acute inpatient rehab facility. So these are patients who had been quite ill with COVID-19 and made it through. The majority had respiratory failure, the majority required intubation, right? And so they were a bit older, as you would expect from patients who ended up in the ICU. And the cognitive battery was the brief memory and executive test. And so it focused on those domains. They were defining impairment in a couple of different ways, which I really like. 1 standard deviation versus 2 standard deviations below age-adjusted norms, so we can sort of get a sense of mild and moderate deficits. And what they show here in this really nice figure is that 81% of their sample demonstrated mild to severe cognitive impairment there on the inpatient rehab service. The deficits were most common in working memory, with 55% of patients showing weakness, set shifting, divided attention, both in the sort of upper 40s in terms of percent, and processing speed at about 40%. There were also high rates of difficulties with orientation, but patients are on a hospital floor. They've been hospitalized for a while, so it's always a little bit tricky to know whether that's sort of delirium versus just not having a good sense of what day it is. Cognition was not significantly associated with how long patients had been intubated or how long they'd been off mechanical ventilation. It also wasn't related to their psychiatric status or pre-existing health conditions. And with respect to their psychiatric status, 23% met criteria for an adjustment disorder, and another roughly 15% had sort of anxiety and mood symptoms. So these data suggest that in hospitalized patients that require a post-acute inpatient rehab, cognitive deficits really should be expected in a large proportion. It really parallels sort of pretty cleanly the critical care literature that we talked about earlier. And then these are data taking us back to Spain from the largest sample that I've seen thus far. And I apologize, I should have prefaced my talk that if I've missed a cognitive outcome data, I would gladly welcome somebody making me aware of any additional studies that are out there that go beyond sort of screening measures, because I'm always wanting to make sure I don't miss something. But in any case, these data are from 179 previously cognitively and psychiatrically healthy patients who were treated in Valencia during the spring of 2020. And so these patients were tested about 2 months post-discharge. So this is sort of the furthest into the recovery process for data that we've seen thus far. And they defined impairment as 1 and 2 standard deviations below age, sex, and education adjusted norms. They used a very nice cognitive battery that's pretty akin to the types of tests we use clinically here. But a brief battery, so they're looking at learning, memory, working memory, and semantic fluency. And what they found is that 59% of their survivors produced at least 1 score in the moderate range of impairment across those 4 tests, with 18% scoring in the severely impaired range, less than the 2nd percentile on 1 of those 4 tests. And moderate impairment was most frequent on tests of learning and fluency, so around 35%. Rates of impairment on tests of memory and working memory were a bit more modest, depending on how we're thinking about, this is about 20-some% of patients showing verbal memory deficits as defined by the 16th percentile or lower, so probably a little bit more than we would expect, but not necessarily elevated rates for working memory. And from an array of disease and patient characteristics, it really was delirium and elevated psychiatric symptoms that were associated with increased risk of cognitive impairment. And psychiatric morbidity was fairly common. 39% reported or produced an elevated score on measures of anxiety, depression, or PTSD. So those are data for sort of that 2 months out, and patients who are really healthy but had a hospitalization for their COVID. So sort of another piece of the puzzle, but doesn't give us really a comprehensive look yet. And I think we're still going to be waiting for those data. And then the last study, these are really fascinating data out of a group from Northwestern. This is a prospective study of patients seen in their post-COVID clinic. And there were 50 patients who tested positive for COVID and 50 patients who had clinical symptoms, got a COVID test, and tested negative. Presumably they had some other virus or illness, right? And they were seen clinically from May through December of 2020. And so these patients were not hospitalized. These are folks who had persistent symptoms at 6 weeks, so sort of meeting that long hauler definition. And they were evaluated 5 to 6 months after the onset of their symptoms. So we're really seeing sort of how patients are doing months down the line. It should be noted that these patients were young, an average age of 43. They were majority female, 70%. And there were very high rates of comorbid anxiety and depression across both the positive and negative COVID groups, although it did tend to predominate in the COVID positive group, which is something to keep in mind. But the groups didn't differ on a number of other comorbidities or demographic characteristics. And what they found is that, these are just some of the symptoms that they were asking about. And I think that what's really relevant, while we're seeing 81% of patients reporting brain fog at 5 or 6 months out, 85% reporting fatigue, we're seeing high rates of headaches, numbness, tingling, etc. But what we're not seeing is group differences in many of these outcomes. The only area in which patients with COVID had statistically more higher rates of symptom reporting was with respect to loss of sense of smell. But contrast that to blurred vision, which was higher in patients who did not have COVID-19. right? So it's really sort of interesting. And then a subset of these patients underwent testing with the NIH toolbox and completed a few of the promised quality of life measures. And this here, again, the numbers are a bit slanted more towards COVID positive patients, with 22 in that group versus 12 in the COVID negative group. But what we see in terms of quality of life is that both groups are reporting diminished quality of life relative to the normal US population, but they're not differing from one another in any statistically significant manner. Additionally, we see sort of that paralleled where the groups are performing more poorly, particularly the COVID positive group in terms of attention and working memory, but they're not differing from one another. So they're performing below expectations normatively, but we're not seeing that the COVID infection necessarily tracks with those cognitive outcomes. And here, you know, attention is statistically significant for COVID positive patients, but the COVID negative patients have the exact same mean, and the range is pretty similar. And so this is just likely a power issue here for these patients. So it really provides interesting data regarding what is the most, you know, appropriate control group for COVID patients. It also raises, you know, we need to be thinking about these sort of normative data for mental health and cognitive outcomes, particularly the mental health quality of life issues. I think it's important to realize that those were captured before the pandemic. And we know that sort of the rising tide lifts all boats, that rates of psychiatric distress more generally during the pandemic in individuals who are not affected by COVID, that those are going up as well. So sort of our pre-COVID norms might not also be the most appropriate comparison group, because we're seeing higher rates of psychiatric distress and in the population at large. But I think across these 5 studies, I think the thing that really stands out to me is that there is yet to emerge a clear picture of the cognitive domains that seem to me to be most vulnerable in the setting of COVID-19. And with that, I'll turn and start to tell you a bit about our clinic. As Joshua noted in the beginning, this is one of the earliest dedicated multidisciplinary COVID-19 survivorship clinics in the nation. It was conceived of in March of 2020, and they saw their first patient in April. I saw my first cognitive data for patients in June, early June, maybe early July. I may be wrong on that, right? And so this is a fabulous clinic run by Ann Parker and Emily Brigham, who are pulmonologists. They've just done a fabulous job setting up a multidisciplinary infrastructure that really does serve and treat the whole person. And so it's a close relationship between pulmonary and critical care medicine, our Johns Hopkins physical medicine and rehab group, and our home health care, who's really involved. They were donning all the PPE and going into patients' home and doing physical therapy and monitoring their oxygen and things like this early on in the pandemic. And so it's a really great group. We have lots of psychiatry, psychology, rehab psych, neuropsych, neurologists on our clinic. And the way this works is that we serve patients in sort of one of 2 pipelines. One is our patients who required at least 48 hours of ICU care. Right, so those are patients who are hospitalized. They needed to be in the ICU for at least 2 days. Our other clinic serves patients who they may have been hospitalized or maybe not even been hospitalized, but they have ongoing pulmonary issues that link them back into our pulmonary team post-COVID. And so they're having sort of a recovery difficulty, and so that gets them into our system. And so as part of their clinical care, around the time of a patient's first follow-up PACT visit, our patients undergo a clinical cognitive testing battery that's administered over the phone. And this battery was derived from the multi-ethnic study of atherosclerosis, the MESA study, and the NAC uniform data set. So 2 batteries where they've got a lot of experience in administering this over the phone and know that we can get valid data. We defined cognitive impairment in 2 ways. Trying to be fairly conservative, so 1.5 standard deviations below age-adjusted norms and 2 standard deviations. Additionally, we know that the more tests that are in a clinical battery, the higher likelihood of producing a weak score, sort of by chance. And so we conducted statistical analyses to determine whether the rates of impairment, as we've defined them, exceed what we would expect on a battery of 8 individual cognitive tests. Right? And so we also administered some mental health outcome questionnaires, the PHQ and the GAD-7, as well as the impact of event scale, which was administered only to those individuals who were in the ICU. And then we assessed functional decline with the Quick Dementia Rating Scale. And our battery overall was administered in English and Spanish. I'm going to be restricting our discussion today to our English language data. And it really is sort of the very first, our first participants. These are our first 82 patients who came through our clinic. They were assessed between July and January. On average, 70 days, so about 4 months from their first positive test. Our patients were in their middle age. We had slightly more women, 59%, and our group is majority minority, which is consistent with the Baltimore metro area broadly. Our patients were bright and well educated, but as you might expect, our patients who required ICU care, they were somewhat older than our patients who did not. They were slightly less educated, but they had slightly lower estimated IQs, but still solidly within the average range. Our clinics did not differ with respect to the breakdown of sex, race, ethnicity, or time since the initial COVID diagnosis. And so when we look here at our age-adjusted standard scores, we're seeing clearly that for many of our cognitive tests, our patients are performing below that sort of 100, give or take ballpark range. And we see clearly that patients who are treated in the ICU in the dark blue lines tended to perform more poorly than their non-ICU counterparts. And we're seeing very high rates of deficits in verbal fluency, processing speed on the oral trail making test, learning and memory on the Ray-VLT. But we're not seeing profound deficits in executive skills, a simple auditory attention, or working memory across either clinic. And when we think about just a cognitive composite of these 8 scores, our patients who are not in the ICU are scoring about 1/4 of a standard deviation on average below expectation, where that's about 2/3 of a standard deviation for our patients who did require ICU care. And this is just another way of sort of showing these data, highlighting that more than 1 in 5 patients are producing low scores on tests of learning, memory, speed, and fluency. Overall, 2/3 of patients produced at least one mild, moderate deficit on at least one test. And when we're trying to be sort of more cautious and look at rates of at least 2 impaired scores, mild or moderate or severely impaired scores, we're still seeing that our patients are showing rates of impairment that exceed statistical expectation for a battery of this length. So even among our patients who are not seen in the ICU, nearly 1/3 are producing 2 scores that are more, below the 7th percentile. 15% are producing at least 2 scores out of 8 that are below the 2nd percentile. So it really is beyond sort of what we would expect statistically if these folks were healthy and doing well. Additionally, 78% of our patients reported at least a mild elevation on one of our mental health and functional outcome measures. 35% of patients reported moderate elevations on at least one of these. And so our groups aren't differing across clinics. We're seeing relatively high rates of mild symptoms of depression. A lot of that, I'll tell you, is fatigue. We do see a slightly higher proportion of moderate symptoms of depression among our patients who did not require ICU care. Anxiety is fairly evenly distributed across clinics as well. At 4 months out, 1 in 4 patients treated in the ICU are reporting clinically relevant symptoms of PTSD. And then we're seeing fairly high rates of functional decline, self-rated functional decline. And for those who aren't familiar with the QDRS, mild, here I'm more inclined to clinically interpret mild declines as clinically relevant. And this measure consists of 10 items, only 3 of which are related to things like getting around, toileting, sort of the more basic and instrumental ADLs. The other 7 items tap into functional declines due to changes in thinking or changes in emotional functioning. And so I think what we're seeing is that these rates of cognitive difficulties are translating over into functional difficulties for our patients. So the major findings are that at 4 months, we're still seeing relatively high rates of cognitive difficulties in patients who are seen in a pulmonary follow-up clinic. This is most common in processing speed, fluency, as well as learning and memory. Our ICU patients are showing broader and more severe deficits, and both groups are showing clinically meaningful levels of psychiatric distress and functional decline. So I think if we sort of think about where all of this is leading to us, I mean, I think that the large longitudinal studies of neuropsychological outcomes are going to be really, really important. We need to figure out what is the trajectory of cognitive recovery, and hopefully it is one of recovery. What are the nature and duration of the deficit? Sort of what is that pattern over time? What are the patient disease and treatment characteristics that predict poor outcome? We have to remember that these are patients who were tested early in the pandemic, relatively speaking, and treatments have really come a long way. More patients are getting vaccinated and are getting, when they're contracting COVID, they're not getting as severely ill. And so it may be that with better disease treatment, we're going to see better neuropsychological outcomes as well. We need to be thinking about what is the most appropriate control group for our patients in light of the data out of Northwestern showing that non-COVID viral control group really makes a difference, or seems to. We need to understand the underlying biology and neuroimaging characteristics of prolonged symptoms. And because of the both direct and indirect mechanisms that we think contribute or can contribute to neuropsychological outcomes in COVID, we really want to be looking at whether, particularly our older patients, are going to be at increased risk for neurodegenerative conditions because of that sort of inflammatory cascade that they may be likely to experience associated with their COVID. And then, of course, we need to be thinking about how the infection is affecting the clinical course of our patients with other conditions, with multiple sclerosis and movement disorders and all of these other things that get patients in our door. We're going to be asking about COVID now and whether they've had it and what their course was like, and trying to integrate what we know about cognitive outcomes to sort of parse out what we think is due to that illness versus their underlying neuropsychiatric or psychological disorder. And I wanted to make sure I sort of ended with getting this slide in because it's just such a beautiful figure. The work is not quite yet published yet, but this is a meta-analysis of symptoms. And I've sort of starred all of those in which neuropsychology and psychology more broadly really can have a role in helping patients get back to their baseline. Future work, there's a lot being done. For those who don't know about the INS Special Interest Group on COVID, it's called the Neuro-COVID International Neuropsychology Task Force. They have put together a manuscript that hopefully will be out soon, talking about sort of harmonizing cognitive batteries and best practices for thinking about assessing all of the symptoms that we know are associated with COVID-19, thinking about how we can do that cross-culturally and in limited resource settings. So I think that'll be a really nice resource for us. Of course, we need to be thinking about how we can increase access to neuropsychological services to patients who have experienced COVID, who are in underserved communities. And the tele and video-based assessment tools are really, proving to be really critical there and are a major step forward. And then we need to figure out what are the most effective interventions for neuropsychological outcomes. Who are they most appropriate for? When should they be delivered? What is the modality that sort of serves our patients best and gets them back on their feet as quickly as possible? So even as this pandemic winds down in the US, the numbers of patients who are really already affected are just so striking. And the extent to which so many of these symptoms really fall within our wheelhouse really suggests to me that neuropsychologists are poised to be very key players in thinking about how we assess and care for these patients moving forward. And so I wanted to leave enough time, hopefully I did good, for questions if there are any. And I want to make sure that I just give credit to all of the wonderful people that I've been working with over the past year. It's been a really, really fun team, and I'm happy to be involved with the work they're doing.
Yeah, thank you so much for this presentation. I'm sure for all of the many people in the audience, and myself included, it's extremely helpful at the pivotal time. We've crossed the 1 year mark of this being a role or a disease that impacts our clinical work. So it's really helpful to hear kind of literature, and it's exciting to see the data you've been published or about to publish hopefully soon that you bring here for us. So there are a few questions in the chat that I'll kind of integrate. And if other of the attendees have questions, you can put it in the Q&A box or put it in the chat for us. And I'll try to do as many questions as we can over the next 10 minutes or so. So one question was about the methods actually of your testing. I just wanted to clarify, was the neuropsych testing that you did, was it in person or was it via telemedicine?
It was all over the phone.
Okay.
It's all over the phone. And actually, I didn't present any data for our Spanish language patients, but about a quarter of the patients who come through the PACT here in Baltimore clinic are Spanish speaking. And so the phone is actually a much better way to get a hold of those patients. Even though we think everybody has a cell phone, data plans really limit how much patients are willing to do over video platforms. And so we found the phone really to be pretty useful.
Yeah, that's a really good point. But that's helpful to know kind of that's the context in which the study was done. One question, another question comes in asking about what was the criteria for referring patients for this neuropsych evaluation at your initial clinical visits? And then also as a follow-up, they're saying that many of us right now are being asked for kind of like what's a good cognitive screening measure to appropriately direct care flow at the initial visit for a COVID patient or a post-COVID patient. So in addition to the criteria question about the referral, what are your thoughts on some of the screening measures out there that could be used? Is there a kind of a gold standard measure or an emerging gold standard measure?
Yeah. So for the first issue, so how patients sort of get to us. So as I was saying, anybody who's in the ICU will get referred to the PACT clinic, and they will get a phone call from our cognitive testing folks, or patients who weren't hospitalized, or at least not hospitalized in the ICU, but are having these prolonged symptoms. They're in our Hopkins network from one of our hospitals. And so they get in, everybody's offered the assessment. They get a phone call around the time of their first visit. And some people take us up on it and some don't. And so we don't have great data on sort of which patients we can't capture, we just can't reach them, which patients are refusing and just not interested. We've certainly seen more patients than this. So these are data for the first 82. I think I've got, we're certainly up over 200 now, but the PACT clinic itself has seen many more patients than that. And so it is a select group that's making its way to me. And I think that particularly for our non-ICU group, that's going to be, we have to think about sort of referral bias and how these patients may differ, who are asking for follow-up care and willing to get cognitive testing and do more psychological questionnaires, how they may differ from COVID patients more broadly. And I think that we saw that in the Northwestern data, where we're seeing really high rates of women, very young, with a lot of psychiatric comorbidities, who are having these sort of prolonged concerns. And then in terms of the best screening, that's a great question. And we keep waiting for there to be sort of objective data to say, okay, we're seeing a lot of processing speed, or we're seeing a lot of working memory or attention. And it just seems to be less consistent than I would like. People are having good luck with the tics and with the MOCA, which can be done over the phone with patients to sort of identify broadly cognitive difficulties. And there have been lots of studies looking at that. At those measures. I don't think at this point that we have really a great a gold standard at this point. I'll tell you that we get these data, these telephone-based cognitive data clinically. My job then, I read those data and I tell our pulmonologist, this is somebody who we need to see for a full neuropsychology workup. So this isn't sort of the gold standard of what they're getting. It's sort of the first pass of getting them for a neuropsychological evaluation referral, maybe a referral to rehab psych to help them work through some of their anxiety and depression that they developed. Some of our patients certainly have pre-existing neurological and psychiatric issues, and so they need to be referred out for psychiatry and longer term psychotherapy, and we're really that sort of first pass. Maybe they haven't had doctor's visits in years, and so we're sort of, this is an opportunity to get them into those clinics. But this is, we have sort of a broader battery that we're administering clinically to folks when they make it that far down the pipeline.
Yeah, that's awesome. It's really helpful to hear your opinions on both of those questions. One question too, I guess, because you actually mentioned this, some of the data that's been, coming out of your study, and this question says that they found it interesting that some of the other studies have found differences in working memory and executive functions, but your study, it seems like it's not as large as maybe some of these other studies, and there's more of a differences in the memory studies or the memory scores that have been coming out of your work. They're just curious if there are any thoughts or hypotheses that have been emerging as to why this might be.
Yeah, that's a great question. I'm not sure. I mean, part of me was actually really happy to see that we had some selectivity in the cognitive deficits that we're seeing. So it isn't something about us doing the testing over the phone or my psychometrist, it isn't necessarily a method issue. also, our outcomes are all, many of them are verbal, right? Because this is over the phone and these are patients with a lung disease. And so I also had the question of, is dyspnea contributing sort of disproportionately to the deficits that patients are having? And the fact that our digit span scores are at or above expected ranges, which also requires that sort of verbal output, makes me think that that's probably not the case. So I'm not quite sure, in truth, sort of what is leading to the deficits. I think part of it is also, our older patients, our ICU patients tended to be older. We're not screening out for pre-existing conditions. This is really a snapshot of what you're going to see in a pulmonary clinic. And so it is the case that some of these folks will have had TIAs or had, unidentified cognitive weaknesses that were there before their COVID, and it's really just sort of coming to light and perhaps confounded by their acute COVID illness. And sort of, we're still going to need to tease all of that apart.
For sure. I think that's good that you're getting a snapshot of the wider community. And I think, Johns Hopkins is a very well situated place to be doing this work too, in a very diverse population. I'm curious, a question I guess more from me, do you know, just side by side comparing the diversity of your own sample against these other studies, could that be at all a contributing factor? Like, are these other groups of very different cultural or ethnic backgrounds than your own?
Yeah, so I certainly think that may be the case. The data coming out of China and Spain, for example, they don't report on racial or ethnic background of their patients. The data from New York and from Chicago, certainly much more diverse. I recall specifically that the New York data, they were majority minority as well. We looked specifically in our underrepresented racial and ethnic minority patients. They didn't differ by clinic, but there certainly was a trend that we saw more members of minority groups represented in our ICU clinic. Then when you look specifically at the cognitive scores for patients, for our minority patients in the ICU versus the non-ICU clinic, we see that our ICU patients are performing more poorly, even though they don't differ in their other demographic characteristics or education or IQ. So there really is something about being more acutely ill that is really driving those differences between our non-ICU and our ICU groups. But I do also think that having good representation is really, really important in this research, because we do have evidence to suggest that our minority individuals are at greater risk of contracting COVID. So we want to make sure that we are doing our studies with the patients who are at risk.
For sure. So these last, I guess, two questions kind of have to deal with the sort of the psychiatric component of the talk that we had mentioned previously. So one question, I guess this is more of a broader question, but I'm just curious if there's anyone who comes to mind for you. One of the audience members asks if they want to learn more about the connection between cognitive complaints and emotional factors, are there any sort of like seminal scholars or anyone who's doing interesting research in this area now that you'd suggest they look at?
Maybe that person could email me and I'll get them some. On the spot, I'm not thinking of anything, although I'm sure, if others have a good idea, please feel free to chime in, because I'm sure I'm just blanking.
Yeah, I invite our participants or whoever to message us in the chat if you're doing a literature search on this now.
Yeah, a lot of my background comes from the cancer and cognition literature, where we see, really that objective cognitive performance is not very closely tethered to patients' own subjective sense of their cognitive abilities, but it's fatigue, it's distress, anxiety, depression. That's really driving that sense that their cognition is poor, sort of regardless of whether it actually is or is not.
Okay. And then the last question, let me just see one thing. Sorry, I lost my question. The last question that we can talk about is, do you think that in terms of, again, the psychiatric component, are there any sort of do you think that individuals with psychiatric conditions might be especially vulnerable to contracting COVID due to systemic or environmental factors? So for example, you said older adults who might be at risk for more dysexecutive functioning might be at greater risk because they might be taking their masks off because they can't maintain that working memory component of trying to achieve that goal. So do you think there are any systemic or environmental factors that might be increasing risk in people with sort of elevated psychiatric comorbidities that could increase risk for their infection? And they also provide, this person says, an example of a Environmental factor might be that they might be working at like lower paid jobs or essential worker jobs. I don't know if there are any other factors or things that you're
Yeah.
curious or wondering about here.
Yeah. I mean, that's what came to mind for me, as well as we know that there are increased risk of smoking in individuals with serious mental illness like schizophrenia. And so they may also have additional sort of pulmonary vulnerabilities because of that as well. But I think that that's a really good point, that it's sort of easier to think about why patients with dementia may be at increased risk because we know that they're having these behavioral difficulties. Psychiatric illness broadly construed, I think there may be subsets of patients that are really going to be more or less vulnerable.
Yeah. And then, yeah, so Dr. Duggan mentioned that we'll ask you if you'll be okay to share slides. Lots of people want to see your slides because it's tons of chock full of good information in this talk. I guess I'll kind of conclude us maybe on one question I'm curious about that I feel would be of help to everybody here who's seeing patients or research participants right now. One thing I'm curious about is, so you are, as I think is a good practice now, even with non-COVID or patients who are not specifically referred for post-COVID sequelae, you're interviewing them and asking them about COVID. What sort of things are you looking for in terms of, or how are you going about that question? Obviously, you mentioned like duration is important, course, ICU. Are there other sort of factors like the stigma components as well, or other things you're wondering about in your clinical interviews?
Yeah, when I come across our patients who are referred from sort of this pipeline of having had COVID, I'm definitely asking them about sort of what else is going on. We know that our patients are experiencing job loss, homelessness, the number of sort of patients that I've seen where COVID has struck right in the middle of other family crises, right? They're going through a divorce, they've lost a spouse, their spouse has cancer, they're experiencing sort of instability in their occupation. And so I think that for those patients who come to me specifically for COVID, that's a large part of sort of what we're talking about. But more broadly in my patient interviews now, I mean, we typically ask, have you ever had, X, Y, and Z? And COVID is in there. And if they say, yes, I had it, they're often patients will say, but it was pretty mild, or, I haven't had anybody just happened into my clinic with having had a severe sort of ICU type of case as of yet, but I'm sure it'll happen at some point.
Yeah, it's just kind of epidemiologically at this point, it's coming, I guess, all of our way. So I guess with that, maybe we can conclude there. We're toward the top of the hour. I just want to say thank you again on behalf of all of us that know neuropsychology, and for our audience for coming today and giving your talk and for your leadership in this area. It's super important, and I'm looking forward to seeing continued work as the years go forward. Just on this last slide, I wanted to mention to everybody who's still here with us that next week we'll have our final No Neuropsychology lecture in this volume. So it'll be week number 12. And we'll be joined by Dr. Bill Barr, who will talk about CTE. And I'm sure it'll be a good talk as well. So thank you again, Dr. Vanderstal, for coming today, and everybody else for joining us. And I hope you have a good rest of your Monday.
Thanks, guys. Thanks, everybody, for being here.
Thank you. Annie, you can